welcome all to the continued medical education program Masterclass on Strabismus by Jharkhand Ophthalmological Society. Today we have a very eminent speaker, Professor Subhash Dadeya, who is going to enlighten all the ophthalmologists across Jharkhand as well as PG students on practical pearls in strabismus. So over to Dr. B.P. Kashyap, our past president, Jharkhand Ophthalmological Society and member managing committee, JHOS, to give introduction of Professor Dadeya.
Hi, everybody. I'm so happy to see a very good number of people join us. So without wasting time, let me introduce Dr. Subhash Dadeya. He's a professor and he's a distinguished ophthalmologist and a professor at Guru Nanak Eye Center, Maulana Azad Medical College, Delhi. And with extensive leadership experience in ophthalmic societies. If you talk of societies, he had been a past president, secretary of Delhi Ophthalmical Society and Establishments and Pediatric Ophthalmical Society of India. He had been the president of JHOS, secretary of JHOS, and president-elect SPOSI, and department director and professor, faculty association president, and RDA president at Maulana Azad Medical College. He is a member as executive member roles in SSI, AIMS, and many others. And he holds very important leadership key positions in many societies. And you can see him talking in all the society general body meeting. You can see he's a lot of genuine and really the pointing points at societies and different laws. He is very good at it. And when Professor Subhash Dadeya says, everybody listens. So now he will say, we will listen. Please, welcome Dr. Subhash Dadeya.
Welcome, Dr. Subhash Dadeya. Before you share your slide, we want to introduce our discussants and office bearers. The office bearers of Jharkhand Ophthalmological Society are our president, Dr. Rajnikant Sinha, our secretary, Dr. Sujay Samanta, myself, Chairperson Scientific Committee and Member Management Committee, our treasurer, Dr. Malay Verma, he's the plastic surgeon. He has also joined. And then, of course, the discussants. So, as discussant, we have our star discussant along with the other eminent discussant. The star discussant of today is Dr. Parikshit Gogate. So over to Professor Sunil Kumar, Riorim's HOD and our JHOS ARC chairman for introduction of Dr. Parikshit Gogate.
Thank you, madam. So it's my privilege to introduce Dr. Parikshit Gogate. So he's an accomplished ophthalmologist and surgeon, specializing in cataract and pediatric eye care with extensive surgical experience spanning 33 countries. He holds MS Ophthalmology, DNB, FRCS, MSc, ex-IPS, FICO with over 400 scientific publications, numerous international presentations, and multiple academic distinctions. He is a leader in ophthalmology organization, and he has served as president of prestigious Maharashtra Ophthalmological Society and as secretary of the International Society of Geographic and Epidemiologic Ophthalmology. He has been editorial board member and section editor for Top Ophthalmology Journal and has held key roles in Global Ophthalmology Society. So we all welcome Dr. Parikshit Gogate. He is also a fitness icon, so we all know for that. So welcome, Dr. Parikshit.
Thank you, sir.
Professor Sunil Kumar, I have introduced him earlier. Then there is Dr. Randhir Kumar Jha. He has done his establishment training from New Delhi AIMS. And currently, He is serving as Professor of Ophthalmology, Darbhanga Medical College and Hospital. He has been extensively trained in RP Center, AIMS, New Delhi as a senior resident in strabismus unit. Then we have Dr. Vandana Prasad. She is the eminent squint surgeon from Jagannath Hospital. Then we have Deepika Kedia. She's a young ophthalmologist trained in pediatric ophthalmology. So now we have done introduction of our discussants. So over to Dr. Subhash Dadeya for his talk. Please share your slides.
Yes, sharing.
स्क्रीन पे
स्क्रीन पे
ये देखना ये सिलेबस ये कर My slides are visible.
Yes, visible.
Okay. Thank you, Jharkhand Ophthalmological Society, especially Dr. Kashyap and Dr. Bharti Kashyap. I'll be speaking. I will be.
Please acknowledge Dr. Sunil, Professor Sunil Kumar, our
It's okay.
ARC chairman.
All office
It's
bearers
okay.
of Jharkhand Ophthalmological Society.
Yes.
So, in the next few minutes, I will be talking few points about the strabismus. Strabismus is a condition in which a person cannot align both eyes simultaneously. Under normal condition, one or both eye may turn in, out, up, or down. I will be touching only the basic points. So, in a case of strabismus, when patient presents to you and you want to take the history, you should ask why the patient is consulting. Does he see well? Does he hold things closely? When is the onset of strabismus? Are there any associated symptoms? Is there any history of intermittency? Is there any history of use of specs? Any history of low birth weight? Any history of patching? Any history of progression? Treatment history, result, and family history of strabismus, they are very important in a patient of strabismus. Then another thing is clues for amblyopia. Amblyopia is a significant health problem. Early detection is critical for success. So we have to see whether there is any fixation preference. Is there any tilting of head? Is the patient rubbing his eyes? Is there any abnormally high blink rate? And the most important thing is if there is resistance for occlusion of the sound eye, which even a layman can find out. So if there is presence of resistance for occlusion of the sound eye, that is significant clue for amblyopia. Then drifting of eyes when child is tired, sick, closure of one eye in sunlight, examination of objects close to eye, and presence of amblyogenic factors. There are various visual acuity on age-appropriate basis for infants, preferential looking, sweep VP, ERG, optokinetic nystagmus. For pre-verbal children's, preferential looking VP, picture charts, Landau charts, Telus acuity cards, and for older children, Snellen's charts, tumbling E charts. So then other examination is when you are seeing the patient, you are inspecting the casually. So you must see, is the child looking well? Is he developmentally normal? Is there any structural defects? the presence of head posture, we must note presence of strabismus, nystagmus, photophobia, and eye rubbing. Then external inspection, we must see the lids. Is there any presence of ptosis, pseudotosis? What is the color? Then these things they point out about DRS, brown, and aberrant regeneration. We must rule out causes of pseudostrabismus, presence of epicanthus, facial asymmetry, wild palpebral fissure, observation and measurement of position of globes. So we must look at that. Ocular motility is the part of the strabismus assessment, includes ocular motility examination. We must see the ductions, versions, and versions, and we must check the convergence, must test for version in diagnostic position of gaze beyond for looking for specific muscle weakness, always look for retraction and narrowing of palpebral aperture, and we must note for any presence of nystagmoid movements. This is the 9-gauge photograph. You are clearly seeing there is restriction of movements here. So we must take the 9-gauge photographs. All refractions need to be corrected in infants and young children. And the refraction is always to be done under cycloplegia, because the refractive power changes from time to time. So refraction must be repeated at every 6 months, and up to 5 years of age, refraction should be done under atropine, and more than 5 years, hometropine or cyclopentolate. Tropicamide is not recommended for refraction in patients of squint. For myopia, you have to give the full correction. For hypermetropia, treatment depends on age of child, degree of hypermetropia, visual acuity, and associated symptoms. Hypermetropia associated with EZO deviations and isometropia needs full correction under cycloplegia. Brief period of atropinization to relax accommodation may be required before glasses are tolerated. We must look for anterior segment, conjunctiva for redness, cornea for microcornea, opacity, pupil size, reaction, any light near dissociation, iris for coloboma, aniridia, heterochromia, lens for opacities, and intraocular pressure in different gauges, especially in restrictive pathology. Fundus examination is a must in each and every case of strabismus, because beware of serious organic diseases present in children that may present as strabismus. Detailed fundus examination to look for any sensory cause of strabismus like RD, PSPV, retinoblastoma, toxocara, albinism, and we must look for any torsional element in the fundus. We must look for fixation, alternate, whether it is alternate or monofixation, whether there is preference, how much preference, fixation is central, steady, or maintained. So normal is central, steady, maintained fixation. Then is there any gross eccentric fixation, unsteady, steady but not maintained, central, steady but prefers one eye. So these are various type of fixations. We must see the head posture, rule out non-ocular causes of head posture. We must analyze head tilt, face turn, chin elevation or depression, assess for near and distance, and we must always look for old photos. We must look for any presence of head nodding or shaking. Then there are various methods for measurement of ocular deviations. Careful measurement of angle of deviation is crucial in planning for surgery. Objective methods include light reflex test, Hirschberg's corneal reflection test, and indications are uncooperative patients, poor fixation, and routine examination. Pitfalls are influence of accommodation is there, angle kappa if significant may mask or exaggerate the deviation. Cover test is gold standard in squint, and prerequisite for cover test are sufficient vision, cooperation of child, and no latent nystagmus. Cover test is further divided into cover test, cover uncover, and alternate cover test. Cover test has to be performed for near and distance. Limitations are white with small forias, microtropia, and cyclodeviations. Then Krimsky's prism test is prism is held before the deviating eye. Modified Krimsky's test is prism is held before the fixating eye in situations like dense amblyopia, eccentric fixation. Pitfall is it underestimates the angle. Prism bar cover test, where progressively stronger prisms are placed before the eye till eye makes no movement. Prisms should be held upright for horizontal deviation. Base should be parallel to the vertical line which passes midline through the nose. For vertical deviations, it should be parallel to the floor of the orbit. No staking of the prisms, and prisms are preferably placed before the deviating eye. It tells you nature of deviation, whether there is presence of isodeviation or exodeviation, accommodative element of the deviation, incommittance, A or V pattern, and primary or secondary deviation. So we must rule out this A and V pattern. Limitations are poor vision or gross eccentric fixation. Optical quality of prisms may limit the test accuracy. Latent or manifest nystagmus may hinder the measurements. PVCT is ideal, Krimsky for infants and young children, and Hertzberg test is very rough method. Synaptophore not routinely used these days. Maddox road test is it measures the deviation, but limitations are it is not possible in suppression. True deviation only in NRC, applicable only for small deviations. Maddox wing road test is to measure the amount of heterophoria at near. Advantage is since patient can read the number, this is more reliable for near. Diplopia charting is very important part of strabismus association. It tells about you whether nature of diplopia. Then we must find out whether this diplopia is horizontal, vertical, torsional, crossed or uncrossed, and it tells about muscle involved in paresis and prognosis for deviation. Haploscopic test are this red-green test, Hess test, and Leach test. Prerequisite is good vision, central fixation, and NRC. Interpretation is chart with smaller field is abnormal. If the field is compressed, consider mechanical cause. Greater inward or negative displacement represents primary underaction. These are time-consuming, and so these are the Hess charting. So this is the abnormal chart. So this is the abnormal eye. Don't forget to check near point of convergence. Don't forget to check near point of accommodation in young children. AC by A ratio has to be measured in each and every case of strabismus. Assessment of sensory status is also very important. Stereoacuity of 40 to 50 seconds implies bifoveal fusion, whereas 80 to 3000 seconds implies peripheral fusion. Titmus fly test, TNO test are the tests which are done for assessing the sensory status, and they have always to be done with polarized glasses. Monocular clue have some influence, and TNO test is to be done with dissociated red and green glasses. Bagulini's striated glasses worth 4-dot test or other methods to use to measure the sensory status. Then another important test is FDT and FGT. FDT is used to differentiate between paretic and restrictive causes. The patient looks into the direction of gaze of limitation. Don't put too much pressure on the globe. Pitfall is apprehension may lead to squeezing of eye. Pushing the globe may lead to negative results. Posterior restriction may not be detected, and in cases of combined etiology also. So this FDT is to differentiate between restrictive and paretic strabismus. FGT is direct measure of the muscle force. It requires awake and cooperative patients, and muscle should be free from anesthesia. Pharmacological investigations to rule out myasthenia gravis should be done where indicated. Radiological investigations, CT scan, MRI, USG, and MRNGO should be done where indicated. And in some cases, this cysticercosis is very common cause of myositis in our part of the country. So you are seeing this ultrasonic photograph of the patient showing cysticercosis. So goal of treatment is aim is to restore good vision to each eye, good binocular single vision, to eliminate double vision if present, to eliminate an abnormal head posture, to improve the psychosocial function and improvement of vocational status. Treatment are non-surgical, optical. In non-surgical is optical, orthoptic, and pharmacological. Then surgical treatment is there. In many cases of strabismus, surgery is only effective treatment. Mainly, three type of procedures are there: recession, resection, and transposition. Local anesthesia is for adult patients. GA is used. If GA is to be used, succinylcholine should not be used as depolarizing agent. Reducing the intraoperative bleeding, slight head-up position of the patient, avoidance of excessive blood carbon dioxide level by hyperventilation, and cautery. During surgery, avoid damaging the muscle sheath and anterior ciliary vessels. Avoid disturbing the fat pad and the vertex vein. Check ligaments and muscle sheath should be disturbed as little as possible to avoid bleeding and scarring. Any attachment of the muscle to the lids and plica should be served to prevent post-operative lid fissure changes. Be careful about superior rectus and lateral rectus muscle by isolating the superior oblique and inferior oblique muscle respectively. Recession is always to be done first. For large recessions, hangback technique should be preferred. Ensure adequate attachment of muscle anchoring sutures. Suture bites should not be too deep to prevent scleral perforation, and they should not be too superficial to cause slippage of the muscle. So where indicated, you can do the surgical modifications in the form of hangback recession, use of loop sutures, adjustable muscle surgery, vessel sparing, extraocular muscle surgeries, and Faden operations. So let's take few clinical conditions like infantile esotropia. In infantile esotropia, you should align the eye before 1 year of age. Optimal surgical result is monofixation. Preferred post-op alignment is plus minus 10 prism diopter. Simultaneous surgery on all four octi are not recommended. Vertical deviation should be timely tackled. Botulinum toxin may be effective therapy in some cases. Systemic examination is must. So for diagnosing infantile esotropia, there is typical triad onset before 1 year of age, large deviation, and no or minimal refractive error. Accommodative esotropia, full refractive correction is the treatment. For non-refractive bifocal myotics or surgery is the treatment. Hypoaccommodative esotropia, surgery is the treatment of choice. For intermittent exotropia, pre-op evaluation, measurement of deviation, you have to measure deviation for near as well as for distance. We have to do the PES test. If we don't do the PES test, then we might be undercorrecting these patients. So PES test is mandatory in each and every case of intermittent exotropia. We must do the 3 diopter test. We must look for lateral incompetence. We must measure the deviation in all 9 gauges to rule out A and V phenomena. Presence of DVD and sensitive status must be evaluated. Treatment of exotropia, surgery is only treatment of choice. Non-surgical treatment is temporary measures. There is controversy regarding when to operate, what is the goal, presence of incompetence, type of surgery, under and over correction. But preferably, we should operate these patients as and when we are comfortable to measure the deviation in these patients. If there is presence of A and V pattern, so if there is presence of V pattern without inferior oblique overactions, then we have to do the transposition. If there is presence of oblique overaction, then we have to tackle the oblique muscles. Then various cranial palsies are there. Third cranial palsy is nuclear palsy. In children, 50% are congenital with aberrant regeneration. We must assess the function of fourth and sixth nerve and whether it is painful or painless. So this is a photograph of case of third cranial nerve palsy. Usually causes are diabetes, hypertension, CAD, tumors, and aneurysm. This is photograph of one of patients in which intracranial lesion was found. So treatment is we have to wait and watch till 6 months. We have to take care of the diplopia, ptosis. Then we can prescribe alternate occlusion prisms, and after 6 months, surgery has to be done. We have to tackle this hypotropia and exotropia. So for exotropia, maximal LR recession and MR resection can be done, or muscle reunion or anchoring surgeries are done, or transposition of SO or disinsertion of SO, and for ptosis, LPS resection can be done. Or for sixth nerve palsy, the causes in adults are diabetes, hypertension, atherosclerosis, and neoplasm. In children, trauma, neoplasm, infection, and hematological disorders are there. So treatment is conservative treatment, prisms, occlusion, and botulinum toxin. Surgery has to be done after 6 months. For partial sixth nerve palsy, resection, and for total sixth nerve palsy, transposition is the procedure of choice. Fourth nerve palsy, we must do the if there is presence of hypotropia which is increasing on the same side and head tilt. So these patients, they usually come with a complaint of problem in reading. Most common problem is they face difficulty in reading, and they come with presence of head posture. So this is case of left superior oblique palsy. Symptoms are asthenopia, diplopia, which is worse in down gaze, image tilting, abnormal head posture. Causes are trauma, ischemia, neoplasm. Clinical diagnosis is there by Park's 3-step test. So we have to identify the type of hypertropia. Then second step, we have to identify whether this vertical deviation increases in leoversion or dextroversion, and identify whether this vertical deviation increasing on tilting the head towards the right or left shoulder. So pitfalls of this Park's 3-step test are myasthenia gravis, DVD, if there is more than one muscle palsy, restrictive ophthalmopathy, and long-standing palsies. So other tests are double Maddox road test, examination of versions, inductions, and diplopia charting. So we have to differentiate between congenital and acquired palsy. Congenital palsy is unilateral, presence of head tilt, presence of facial asymmetry is indicator for the congenital palsy. Large vertical fusional amplitude is another sign. Then we have to differentiate between unilateral and bilateral palsies. Bilateral palsies, they are usually acquired, presence of V pattern, and extorsion of more than 5 to 10 degree points towards the bilateral palsy. Treatment is if there is presence of IO overaction, weaken the IO. If there is no IO overaction, SR weakening is there. If there is presence of SR laxity, we have to do the superior oblique tucking, contralateral IR weakening can be done. In bilateral cases, bilateral Harada-Ito is the procedure of choice. Then some special form of squints are there. DRS. This is case of double elevator palsy. If there is presence of type 1 MAD, then we have to do the inferior rectus recession, and in type 2 and 3, we go for the NEPS procedure. Then there are recent advances in treatment of amblyopia. This pediatric eye disease investigator group compared the daily atropine to weekend atropine for moderate amblyopia, and they concluded weekend atropine provides an improvement in visual acuity of magnitude, which is similar to improvement provided by daily atropine in treating the amblyopia in 3 to 7 year of age group. So weekend atropine is recommended. So then this full-time patching and part-time patching, they have been tried in these groups. So in severe amblyopia, 6 hours patching is as effective as full-time patching, and in moderate amblyopia, 2 hours patching is as effective as 6 hours patching. So for moderate amblyopia, we recommend 2 hours patching, and for severe amblyopia, we recommend 6 hours patching with some near activities. So is it mandatory to treat amblyopia prior to surgery? Classical teaching recommends amblyopia therapy prior to the surgery. Can amblyopia be corrected in adults? The answer is yes. Then these binocular visual stimulations, they are new therapies in treatment of amblyopia. Thank you.
Thank you so much, Dr. Professor Subhash Dadeya. It was a very extensive thing, and you have explained in a very, very simple manner, and you have such a detail that I think every PowerPoint presentation slides were a chapter in itself. One PowerPoint presentation slide had so many things to tell us. Fantastic job. That was Subhash. You were
क्यों नहीं आ
great.
रहा है? So now I request our ex-secretary, Dr. Vandana Prasad, ex-chairman scientific committee, to give vote of thanks to Dr. Dadeya.
Hello.
Yes, you are audible.
Okay. Yeah, a very nice presentation by Dr. Subhash Dadeya, and I think this presentation will be very useful for the postgraduate and the DNB candidates will be appearing for the exam, and a very precise and concise explanation and what should be done in, and especially the recent advances he has covered for the treatment of the amblyopia. That's very, thank you for the enlightenment you have given to all of us. Thank you, Dr. Subhash.
Thank you, Dr.
Subhash.
Vandana.
Yeah, Dr. Subhash, all the best for your coming election. Are you hearing, Dr. Subhash? Are you here?
Sir, I am joining by mobile because in the laptop is problem.
Please stay connected. Remain connected.
Yeah,
we will be soon starting our another CME. Remain connected. 2 minutes. Remain connected.
Dr. Dadeya gave a very excellent presentation, and it's very, very good for exam going students, even for general ophthalmologists who come across squint cases. Sir, you told about recent advances of amblyopia, because nowadays there are so many options which are there for private practitioners to decide dichoptic therapy, various treatments that are available. And you made also a very pertinent point is whether amblyopia can be treated in adults also. And there is a lot of research that is going on, and the jury is still out. But perhaps the human visual system is plastic throughout life. And perhaps in early adulthood, we can definitely try amblyopia treatment. Sir was also...
basically this treatment of amblyopia, my conclusion is this patching remains gold standard in treatment of amblyopia, number one. Other modalities, they will come and go. So one is patching is treatment of choice. Second is this, after this PEDIC study group reports, this atropine penalization has been recommended as an alternate line of therapy in treatment of amblyopia. Third, although ATS recommends that these near activities are of no use, but there are a lot of other studies which says that these near activities, they are very useful in treatment of amblyopia, and we have also done a thesis on this, and we found it to be useful. Fourth thing is, there was a lot of research on this levodopa and carbidopa, and now the recent consensus is there was an article on American Academy of Ophthalmology that enough is enough, and this we must not do anything for this levodopa and carbidopa. It is of not of much use. And fourth thing is this company based modalities, they will come and go.
True, sir. Patching is definitely the gold standard. CT choline was introduced in the Indian market and is still sold 500 milligrams a day.
Yes.
But as Professor Dadeya said, patching is, of course, the gold standard. And 120 hours of patching improves vision by 1 line. So if you patch 10 hours a day, you will improve in 12 days. But if you patch only 1 hour a day, we may take 4 months to improve.
Only
Then actually,
issue
compliance is the issue with the patching. Like as the child grows up now, even the family members, mothers and father are not even motivated. They want the result the next day.
Dr.
So it's
Dr.
not
Deepika,
about the kids, it's more about the parents. Like they keep on roaming around ki I'm doing patching, but I left for 1 week and then start redoing. So the main thing is that parents are not convinced. Actually, Squint, the results are very time taking. So this is the main concern. And as the child grows, he feels shame getting patched in the society. All these practical issues are there, but still I also start with the patching as a first line of therapy. And if the child is having poor compliance or not improving with the patching, then only I try with the software based therapy. And I have come across a few cases who has a squint and high hypermetropia, like +6 hypermetropia. They have shown significant results, like within 3 months of the this therapy, amblyopia therapy, and with the full correction of the glasses under atropine, they have improved the vision to 6669 perhaps, from 660. So at times it also works for some of the children. So we try first of all with the patching only, and if it is not feasible for the parents or kids, then we go for the software based.
Isometropic amblyopias really do well, ma'am. Yes.
Thank you so much, sir.
That-
Which software do you use, sir? Matlab, I'm not having any conflict.
Ma'am, we use Binox more common. We have a publication of more than 160 cases in Binox. But even there, only about 55% improve, 45% don't. So and that too, those who have strabismic amblyopia or those who have a bit of nystagmus, they don't do that well, ma'am. But meridional amblyopias, anisometropic amblyopias do well. But again, we recommend this after having tried patching for at least a year. Only then we try. We don't recommend it as a first line of treatment. Patching is definitely the best. It's when patching doesn't work, or basically parents are not able to make it work, or the child has now become 12 or 13 years and the window of opportunity is narrowing. That is the time when we think of the dichoptic treatment.
Which patch do you use? Usually we use the what is available in the market, not the cotton or the cloth based thing. So do you use the same, or you have some specific choice for the patch?
Ma'am, we have a lot of software people in Pune, so they like the thing which they order from Amazon. But for rural populace, we tell them you get it made from your tailor, जो दर्जी के यहाँ छोटे मोटे कपड़े पड़े रहते हैं, उससे आप बनाएं. And then you can have patches of various colors. So especially with girls, they can have a matching patch whenever they go to school, green or red
Yeah.
or blue. So उनको भी थोड़ा कुछ अलग रहता है. As long as they patch, that is what is important.
Okay.
And
Usually
Dr. Deepika, one thing I would like to add here.
Sure,
This
sir.
compliance for patching is a very tricky issue, but I do one thing. I ask, do the patching and do the mobile game exercises with the other eye. So the childs, they comply.
Actually, sir, with the mobile, they will comply with anything.
Yeah. So
That is Good point, sir. Good point to add in our practice.
Basically, we have tried everything in amblyopia, this part-time patching, full-time patching, levodopa, carbidopa, acetylcholine, near activities, mobile game exercises, and in untreated adult anisometropic amblyopia, this LASIK surgery. And now we have done a thesis regarding use of physical exercises, cycle on the cycle, physical exercises. So the treatment, they are coming and going, but the gold standard still remains patching. In some cases, atropine penalization, and other things, they are adjuvant therapy in treatment of amblyopia.
Thank you so much, sir. Thank you, sir. Thank you, Dr. Parikshit. Thank you, Dr.
Thank you, Dr. Parikshit. Thank
you, sir. Thank you, Kashyap sir, Kashyap ma'am, and Dr. Deepika. Thank you.
It was a very nice and a very useful discussion. So thank you so much. Our next session is about to start probably.